Hi, I'm Sherry Harlan Davis, program host for Reid Beside You. And joining us today is Dr. Anthony Vaca. He is with Reid Pulmonary Care. And welcome, Dr.
Thank you.
Vaca.
Glad to be here. Thanks for having me.
Well, we're highlighting COPD Awareness Month. But before we get into that, share with us on how you came to Reid.
I was working in a hospital in Illinois. We had been there, my wife and I had been there for about 25 years. And Christmas, I think 2020, her family lives in Ohio. We decided to come visit her family, and I was moonlighting for 1 week at Reid in the ICU. And when the week was over, I'd had a really good time, enjoyed the people there. It's a wonderful, beautiful ICU, and didn't think anything about it. And then about 2 months later, they called me and asked me if I was interested in a position because they had found out that my wife lived in Ohio and maybe I wanted to move there. And I said, no, I'd been where I was for a long time and thank you for the offer. And then as things would have it, things changed where I was, at the hospital where I was. They wanted to bring in some more telemedicine and they wanted me to do more intensive care telemedicine, which I'm really not interested in doing. And I could see the writing on the wall, so I called Reid back and I said, hey, are you guys interested in having me come back? And we interviewed and we moved here in October.
Well, we're very happy that you chose Reid.
I've been living in my in-laws' basement for the last year while we're building a house.
Okay.
So I'm glad I'm here, but it'd be better when the house is done.
And how did you become interested in pulmonary, becoming a pulmonologist?
Well, I went to medical school in New England, and then I trained at the Cleveland Clinic, where they had a very, very strong critical care unit. And I really wanted to do critical care. So I had a very insightful director who told me that I really should do pulmonary and critical care because as you get older, critical care starts to wear on you, and pulmonary is the next step in the transition. So I did a 3-year critical care pulmonary fellowship, and turned out that I really enjoyed pulmonary just as much as critical care. And as I've gotten older, I've begun to transfer my services from the critical care line to the pulmonary line. So starting next week, I'll be a full-time pulmonologist at Reid, and critical care will be behind me, I think. So.
Great for new beginnings.
Yes, ma'am.
In layman's terms, what's pulmonary care?
Pulmonary care is the practice of medicine with a specialty toward the lungs, breathing, the chest. If anyone's ever been short of breath or choked on food or had a problem where they were not able to catch their breath, they understand what it means to be short of breath. And some people have shortness of breath for the rest of their lives because of their lifestyle or because of a genetic abnormality. And pulmonary care is the practice of taking care of those patients and trying to utilize multiple different aspects of medicine to improve their breathing.
And what are some of the ailments do you commonly treat?
Well, I think the most common reasons to come to a pulmonologist are for the complaint of shortness of breath or dyspnea on exertion. Dyspnea is shortness of breath when you exert yourself. And there are many, many causes of dyspnea, but the most common is going to wind up being COPD, chronic obstructive pulmonary disease, asthmatic lung diseases. We also see folks for abnormalities on their chest x-ray, lung cancers, lung infections, things along those lines are the most common things we see.
We have, so what is COPD?
Well, COPD stands for chronic obstructive pulmonary disease, and it's really a spectrum of disease. It's not just one disease. And included in that spectrum, at one end we have chronic asthmatic bronchitis, which is manifested by increased chronic production of secretions, worsening dyspnea, cough, bronchospasm, which is narrowing of the airway. At the other end of the spectrum, we have emphysema, which is a damage to the lung because of usually an irritant such as smoking or working in an area where there's inhaled irritants. And that's chronic end-stage damage where the alveoli, or the lung sacs, the air sacs that allow you to get oxygen in, carbon dioxide out, are damaged. So as they become damaged, you have less ability to bring in oxygen, less ability to discharge carbon dioxide, makes you want to breathe harder, faster, makes you short of breath.
And as we are talking, we will have some slides
Sure.
For the public to review as to see what we're looking at. Also, in COPD, often when people hear someone says COPD, is there the people just assume that they were smoking?
They do. And you don't have to have been a smoker to get COPD.
Okay.
So there are other etiologies. The most common is smoking. But really what smoking is it's a chronic damage to the lining of the lung and to the end spaces where air exchange occurs. So smoking is the most common because it occurs in many, many people, and it occurs over many, many years. But people who are damaged or have had smoke inhalation, as in a house fire, or people who have worked in areas where there are noxious fumes for years, those can also cause the same damage to the lung. There's also a genetic predisposition to develop COPD, which is called alpha-1 antitrypsin deficiency, a long name for a disease that does not allow you to your lungs to clean themselves the way it's supposed to. And people who have alpha-1 can develop severe emphysema at a very young age. So we tend to test most of our COPD patients, even if they're not at the younger age, because there can be a carrier state, and you can find people who have this alpha-1 deficiency very early in life, and there are ways to prevent the damage to the disease. So there's lots of ways to get COPD.
And what are some of the common risk factors? Once again, you were saying smoking is one.
Smoking is one. I think environmental, here we don't have to worry about that. We have beautiful air, but large cities, Los Angeles, Beijing, New Delhi, areas where there's terrible air quality, those folks are also at risk to develop COPD because the same types of inhaled gases are in the air as there are when you smoke a cigarette. Nitrates and sulfates that damage the lungs. So workspace environments where there's inhalation of toxic fumes, even environmental where houses that we build now are so tight that there's lack of air exchange, and things that develop in the home that can't be blown out of the home because they're just too tight from their insulation can develop and lead to lung problems, not just emphysema or COPD, but asthmatic lung problems too.
And what are some of the risk factors that we've seen, as well as the signs and symptoms of COPD?
Sure. So I think, like we said, the most common risk factor is going to be smoking or inhalational injuries. Some signs and symptoms. Well, of course, it's going to be shortness of breath. It's going to be a cough, usually productive of maybe some thick, clear phlegm. Trouble sleeping because of shortness of breath. Trouble thinking because of hypoxia. When you develop significant COPD, you start to decrease your ability to get oxygen into the system. So you'll find that people become more short of breath when they exert themselves, and they have trouble waking up in the morning from sleep because when they're exerting themselves, their oxygen levels can become too low, and when they're sleeping, their CO2 or their carbon dioxide levels can become too high. So exertional dyspnea, shortness of breath, cough, sputum production, those are the most common symptoms associated with COPD.
One of the things you were saying was like with the workplace and the environment. We've seen possibly a reduction since with OSHA requirements for different, especially more in the factory environments, that they have to really watch their workplace.
And I think because of OSHA, the air quality in most places is better, but they really don't. They're not able to get rid of all the toxins. I mean, if you're working at a lathe and you're having this oily mix of air come up into your face, there's not a whole lot you can do about it besides wear even more than a mask, but a respirator.
Okay.
And most companies aren't going to pay for that, and most workers don't want to do that. So, and then there are other disease processes, which I know we're not talking about today, but people who are really at risk for lung disease are those that work in coal mines or quarries or foundries where there's actually particulate matter in the air, sand, coal dust. Those people can develop totally different diseases that are more restrictive as opposed to obstructive. Pneumoconiosis is one, coal workers' lung disease, silicosis. So in the workplace, it's not just COPD you have to worry about. There are other inhalational injuries that could occur.
Okay. And what are some of the treatment options?
That's a good question. So it depends on the type of disease we're talking about. So if you have asthmatic bronchitis, you're looking at more of a intermittent, non-totally reversible bronchospasm, where the airway becomes narrowed because of inflammation. So if that's the type of disease we're dealing with, then the first option is going to be what we call an inhaled corticosteroid. So there are multiple medications that have steroid in them. The steroid is inhaled directly into the lung, so there's minimal absorption, so people don't have to worry about, steroid myopathies or osteoporosis or diabetes getting worse because the amount of steroid is so small. That's assuming that we're able to control it with the inhaled corticosteroid. Then there are other medications for bronchospasm or for developing emphysema that allow for opening up of those airways. We call it bronchodilation. So we have long-acting bronchodilators in multiple different types that will allow you to hopefully maximize the lung function that you have left. Breathing tests are usually performed, pulmonary function studies we call them, and they allow you to see whether we're dealing with bronchospasm or whether we're dealing with fixed lung problems, and then we adjust our medication to what the patient shows on the breathing test. And then as you go further down the line, there are other tests to measure oxygen levels when you're at rest or when you're exerting, when you're sleeping. So there's multiple things we can do to qualify and quantify the disease, and then the treatment options are used depending on the patient. It's important that people understand they call medicine the practice of medicine. I call it the art of medicine because each patient is individual and each patient has to be individualized to the multiple medications that are available. So if you're dealing with this type of problem, you really need to see a specialist so we can outline what the disease process has done to you and then maximize therapy for you so you can live your best life.
On a very basic level, after not with just with COPD, but I was thinking of something that people can relate. When after you have a surgery, and a lot of times then you have to blow into the...
Sure. That's called an incentive spirometer.
Okay.
Right. So when you have surgery, well, you're an active person, I'm an active person. We go out and we do the things we do, and when we're sitting here talking, our lung function is minimal. It's just baseline lung function. But the more we do, the more oxygen we consume, the harder our lungs have to work. Mm-hmm. So exercise tones the lung, or rather the chest musculature, and allows you to do more work with less energy expended. When you have a surgery, especially if it's a large surgery, then you become deconditioned. So it's hard to get out of bed, it's hard to continue to climb up the steps because your muscles aren't what they used to be. Same thing happens with your respiratory muscles, so you have to train them again. When you don't take a deep breath, the lungs, instead of being fully expanded, they collapse down a little bit. And you develop lack of air in the bases of the lung called atelectasis. That device you were talking about, the incentive spirometer, allows you to open the lungs back up, clear out the secretions, and allow you to get back to your baseline function. So exercise is probably the best thing you can do to continue to have adequate lung function, even at the end stages of COPD. We can get you into pulmonary rehab. We can make your muscles stronger so that your lungs have to do less work to do the same amount of work for your body.
Okay. And let's talk about the screening, lung screenings.
Okay.
And preventative care.
So I don't really know about lung screening. I think that those tests aren't really done until someone has a complaint.
Okay.
So let's assume that you're not able to perform I call them activities of daily living, things you normally do without being short of breath. People come and they say, "Doctor, I can't climb a flight of steps. I can't bring my groceries in anymore." That's a little higher level of activity where you're starting to see the beginning of the problem. So what we'll do is we'll bring you in for a screening pulmonary function study. And that's really a simple test. You're put in a little glass box and you have to blow and suck and blow. And it measures multiple areas of your lung. It measures the ability of air to flow out of your lungs appropriately. It measures the volume of your lungs, and it measures the ability of the lung to bring oxygen in and carbon dioxide out. If those tests are normal, then we're not dealing with a basic lung function probably, unless it's a much more sophisticated lung problem. Then we look at other reasons why you might have trouble with dyspnea, shortness of breath. Maybe you have sleep apnea, or maybe you have a cardiac disease, or maybe you have a muscular disease. So we'll do a chest x-ray and then go from there depending on what we see from the screening of lung function and from the chest x-ray.
And what does a typical patient look like? I know there's no one that fits
me.
So me.
A typical patient, it's difficult to say. It depends on the extent of disease. The problem that I see is that you talked about screening, and there really is not a good test for early screening. Mm-hmm. So a lot of people don't pay attention to the early warning signs of a little bit of cough, a little bit of wheezing when I wake up in the morning, a little bit more short of breath. And what happens is we wind up seeing patients come in with much more advanced disease than we need to. So most of the patients that I see are anywhere from 40 to 70 years old. They're normal people, just short of breath. I'm talking about early disease. Okay. As the disease progresses, then you start to see people who are more short of breath. They're usually cachectic, meaning they can't hold weight because they're using a lot of energy to breathe. They'll breathe quickly. It's called tachypnea, so they're breathing fast. They cough a lot. But mainly they're short of breath, oftentimes short of breath at rest if they've waited too long.
Someone was coming in to you the first to visit the first time to see you. What
Sure.
do they expect?
They can expect me to spend a lot of time asking about their history.
Okay.
Okay, because history really defines the person as far as their COPD goes. So we'll talk about childhood diseases such as asthma. If it depends on what the disease process is, but oftentimes childhood diseases are, you recover from the childhood disease, but it's left a problem in the body that doesn't manifest itself until you become older. So we'll talk about your childhood, we'll talk about your activities such as the workplace environment, we'll talk about any surgeries you've had, we'll talk about your abuse is not a good word, but
Misuse.
Cigarette,
We'll
alcohol,
misuse.
of alcohol, marijuana now that's becoming is legal is also toxic to the lung. So we have to worry about folks who maybe imbibe too much. Alcohol can cause problems, and then there's of course misuse of drugs that we talk about. We'll talk about children. We'll talk about siblings, family members, because usually there's a propensity to develop these diseases in a cohort or family unit.
So a very interesting and long conversation per se.
Usually it's about an hour for the first time we talk, sure.
Okay.
Yeah.
And so, I mean, listening to you, it sounds like you have a very interactive approach to your patients.
I try to. I think you have to make your patients comfortable with you to talk about the things we have to talk about. And then I've found that as I've gotten older, you really need to understand people's lives before you start to tell them how to live their life. So someone who smoked 2 packs of cigarettes a day for 30 years isn't going to quit smoking tomorrow. May not quit smoking ever.
Right.
But you still have to understand that that's an addiction that people need to deal with, and help them the best way you can to at least understand what the cigarettes are doing, and then maybe find ways to help them back off on the amount of cigarettes they're smoking, things like that. So we try to make it interactive like this, as opposed to, I'm the doctor, you're the patient.
Listen to me.
That doesn't work. Yeah, that doesn't work. Not anymore, anyway.
Can we go? One thing that, when you were saying with family history, you find out about the comorbidities.
Sure.
Can
So
you explain that to us?
Sure. There are things that make you think about a disease process. Have you ever wondered why? My grandfather was 96 years old. He smoked for 65 years, and he died of a heart attack when he was working out in his grapevine area, right? And there are others who come into me that are 40 years old, and they have very, very severe emphysema after only smoking for 20 years. So there are risk factors that we look for that might have led to the rapid progression of the disease. I think that folks who have diabetes, hypertension, heart disease, a family history of COPD, sleep apnea, those things all tend to develop as you develop COPD. So not only are you looking for the COPD itself and for the causes of it, but you need to treat the comorbidities so that the patients can have the best outcome. You can't tell someone who weighs 300 pounds that you're short of breath because you're overweight, and there you go. You have to understand that obesity is also a problem, and that shortness of breath is my purview regardless of the cause of it. So we have to help folks get through these other problems, their diabetes, the heart disease, all work together to make a healthy unit or an unhealthy unit. So you can't just focus on the COPD and say, that's all I'm doing, now go somewhere else.
Right.
It doesn't work, right?
One of the challenges when you were just saying if someone's 300 pounds, they're often, and they're waiting, and they have waited and waited to finally come in to see you. So the last thing they want to hear is you're sick because you're 300 pounds.
That's correct, and that's not always the case. As a matter of fact, it's rarely the case. It's usually part of the problem. But I find that you're a physician first and you're a pulmonologist second. So in our office, we try to help people get to the places they need to get to deal with all the problems, not just the lung problems. So.
And what, so since you're going to be transitioning to full-time pulmonary care, and we're so excited that you're going to do that because our community definitely needs that. So I know you shared earlier that what's the biggest thing you're looking forward to?
No phone calls at nighttime. No, critical care
think about that.
was great for me. Critical care is an excellent field to be in, but I'm just going to lay it out there. It's a young man's field, and I'm not a young man anymore. So I think I'll be able to spend more time with my family. I'll have off the weekends, I'll have off the nights, and I'll be able to focus on the pulmonary department. Reid has an excellent pulmonary department. There's one other physician right now and 2 nurse practitioners in the office with me. We're very busy, and we're trying to expand our range of being able to deliver these services. So we'll be in Connorsville and Newcastle and Greenville, Ohio now, with plans to go to Winchester in the future, and then maybe further in Ohio as well. So I'll be able to just focus on having those places staffed.
So how are patients referred to your office?
They can be referred by their primary care provider. They can refer themselves. They can be referred by their friends or family. I don't have the number with me, but I'm sure it's somewhere.
We have it.
Right? That they can call
Here we have it.
and request. That's a lovely picture. They can request an appointment, and we try to set people up as quickly as we can, and we don't turn away anyone. If you don't have to have a referral from a physician, you can refer yourself.
So the good news is for the public that they can do a self-referral.
Oh, absolutely.
And
yes.
just calling
Absolutely.
that information. Well, we want to thank Dr. Vaca for joining us today on Reid Beside You.
It's been my pleasure. Thank you.
Thank you.